As I was doing some research for this video, I came across a YouTube Shorts video by Joe Rogan on sleep apnea with 7.5 million views. He described sitting next to an obese man on a plane who kept gasping and choking every time he fell asleep. When the man woke up, Rogan insisted that he get checked for sleep apnea. He probably saved this man's life. Once this passenger reads up on the dangers of untreated sleep apnea, it's likely that he'll find that it significantly raises the risk of heart attack, stroke, car accident, cancer, dementia, and sudden death. And this is the short list. Hopefully, he's now sleeping much better either with a CPAP machine or a mandibular advancement device. It's odd that most YouTube videos on sleep apnea have relatively modest view counts, with only some major academic centers occasionally getting over 1 million views. While more awareness of the dangers of sleep apnea is important, the way that sleep apnea is portrayed by doctors as well as by celebrities is the stereotypical snoring, middle-aged, overweight man with a big neck. While these are the most common features that place you at a higher risk, you don't have to have any of them to have sleep apnea. So here are 5 common myths that most doctors as well as the general public believe. At the end of this video, I'll explain the real reason why thin people can also have sleep apnea. Number 1, you have to be an overweight man with a big neck to have sleep apnea. False. Studies have found that you can be a young, thin woman and still have severe sleep apnea. This review study reported that about 20% of adults with sleep apnea are not obese, and of this group, 5% have moderate to severe symptoms. And by far, women are much less likely to get diagnosed with sleep apnea compared to men. There was a study I read decades ago that found that when a woman presents to the doctor complaining of sleep problems, she's much more likely to be given something for insomnia, whereas for men, they're more likely to be referred to a sleep lab to check for sleep apnea. Number 2, if you don't test positive on a sleep test, then you don't have obstructive sleep apnea. False. This situation happens because of the way we define an apnea on a sleep test. Apnea is a generic term that means you stop breathing, but on a sleep test, it has very specific conditions. Your breathing has to be complete with no airflow at all in the mouth, along with respiratory effort in the chest or abdomen for 10 seconds or longer. Hypopnea on a sleep test is defined as less than 30% drop in the nasal airflow signal for more than 10 seconds, with oxygen levels dropping 3 or 4% with or without brainwave arousals. The specifics of which numbers or criteria are used depend on the sleep lab's protocol. And for Medicare patients, there are different rules as well. Really confusing, right? The final calculated score on a sleep study is called the Apnea-Hypopnea Index, or the total number of apneas plus hypopneas overall per hour. And to achieve a diagnosis of sleep apnea, and you have no other symptoms, you need an AHI of 15 or greater. If you have various symptoms or complications of sleep apnea, such as daytime fatigue, memory problems, high blood pressure, heart disease, or depression, then your AHI can be above 5. For any treatment to be covered by insurance, you need to have a positive sleep apnea diagnosis. Now let's say that you undergo a sleep study and you're found to stop breathing 27 times every hour, but the duration is always less than 10 seconds. So what's your AHI? 0. Your problem is not due to lack of oxygen. You feel lousy because of your frequent arousals from deep to light sleep or awake states. This is called upper airway resistance syndrome, and this is what's causing all your symptoms. I wrote extensively about this on my blog and my book Sleep Interrupted, as well as on this YouTube video. So you can imagine that there are probably millions of people with the condition who don't meet the official criteria for sleep apnea and don't get treated appropriately. But if you look at sleep apnea in general, even with what we know about the dangers of sleep apnea, it's estimated that only about 20% of people with sleep apnea are diagnosed and treated in this country. You can imagine the enormity of medical complications that are aggravated even more, such as obesity, diabetes, heart disease, and dementia, not to mention car accidents. And number 3, if you don't snore, then you don't have sleep apnea. False. For the classic sleep apnea patient who begins to snore after gaining some weight, it's pretty straightforward. The airway becomes more narrow behind the soft palate with more weight gain and fat accumulation. The palate begins to flutter with each breath in. This is why weight loss is so important if you're overweight. It's estimated that losing only 10% of your body weight will lower your sleep apnea severity by 26%. But what if you're small to begin with and have small facial bones? This means that the airway is more narrow to begin with, and various other factors such as gravity due to sleep position, inflammation from allergies, colds, and acid reflux or even hormonal changes in women can narrow the airway, skipping the snoring phase altogether and leading straight to obstructed breathing. The nervous system in this situation tends to be normal or hypersensitive, from deep to light sleep quickly, whereas with sleep apnea patients, the breathing pauses during an apnea may last much longer, leading to low oxygen levels. This is thought to be due to desensitization in the throat of the protective airway pressure and chemical sensing reflexes. Two of the more obvious conditions that lead to this process in people with sleep apnea are acid reflux and acoustic trauma from the snoring vibrations. Think of how your hand feels after holding a vibrating sanding tool. Studies have shown that if you have chronic acid reflux, you need a much higher level of sensory input to activate the protective cough reflex in your throat. And people who snore have much wider two-point distances they can sense on the soft palate if pricked with two sharp objects. And anatomically, this makes sense. In facial plastic surgery, the ideal chin position in the profile view for women is more recessed or retracted, whereas for men, it's more protuberant or pushed forward. And if you look in the airway, the space behind the tongue is more narrow as a result of the jaw being more recessed in women. I'm going to hypothesize that despite having a more narrow airway, having estrogen and progesterone in women protects the airway somewhat by giving the tongue more muscle tone. Actually, progesterone has a much more powerful effect as an upper airway muscle stimulant and dilator. This is why some women have reflux and cold symptoms just before the periods as progesterone levels fall. I wrote a blog article about this which received the highest number of comments on my blog, over 1,000. I also did a video on this topic called Throat Pain with Period Flu, What Can You Do? Number 4. There's a cure for obstructive sleep apnea. False. Actually, in medicine, there's nothing that literally cures you of your ailments. It can be treated by doctors, but only the body does the healing. This concept stuck with me since I heard this given to students on the first day of medical school. As I explained in my book Sleep Interrupted, modern humans are all susceptible to breathing and swallowing problems to various degrees, all because we can talk. With our complex ability to talk and communicate, the other more primitive functions of swallowing and breathing are compromised. I'm sure there may be exceptions to this, but as far as I know, only humans choke and die. If you look at human faces only 100 years ago, you will see that they look different. Their faces are wider and shorter, with better cheekbones. Take a look at this figure from a paper that looked at how faces have changed over the decades. They created composite photos of high school yearbooks from 1900 to 2010. You can clearly see that modern faces, especially for boys, are much more narrow and taller. They don't show profile photos from the side, but it's likely to show more recessed upper and lower jaws as well. There are a number of different documented reasons for this, such as shifting to softer processed foods, less breastfeeding, more pacifier use, and nasal congestion. I'm going to add a few more things that we're exposed to in modern countries, such as fluoride, xenoestrogens, and various pesticides, herbicides, and fungicides, including glyphosate, the most widely applied weed killer for crops in the world. I won't get into all the other reasons why this is happening, so I recommend you watch my video, 7 Surprising Reasons Why Your Teeth Are Crooked. Everything that we do to treat sleep apnea is less than ideal. Some are very radical, such as double jaw surgery and tongue pacemaker technology. Unfortunately, the more aggressive the treatment, the better the long-term results, but with more potential downsides or complications. Ultimately, there's no ideal treatment for sleep apnea. Everyone will prefer one over another, and even if it works, it usually doesn't last forever. So I predict that as we as a society become more modern, our faces will continue to shrink even more, with more dental crowding and even more health problems as a result. Sadly, a certain Asian country, Korea, is actually popularizing cosmetic or even jaw surgery to narrow the face, perhaps to mimic the small pointy jaws that are found in anime cartoons. So as this process of facial bony shrinking continues, on top of the obesity epidemic, are we doomed to the movie WALL-E's prediction of all humans being tethered to hovering wheelless chairs during the day and CPAP machines at night? And lastly, number 5, this is the common statement by different types of practitioners in different fields who say that their particular treatment option is the best. False. I may get some pushback on this issue. I was trained primarily as a surgeon and also a sleep medicine doctor, but the most important concepts I learned about came from a handful of mentor dentists. The very first one who opened my eyes to the importance of the airway to dental and jaw development was Dr. Brian Palmer, who sadly passed away in 2012. Over the years, I've worked with many specialists who deal with sleep apnea, including dentists, other surgeons, sleep medicine doctors, sleep psychologists, myofunctional therapists, industry representatives, and various other people. Obviously, everyone has their own biases since all are involved in a business. But how are you as a patient supposed to navigate the system where, for the most part, experts tend to downplay other treatment options? If you look at the published studies comparing one treatment to another, there's usually no clear winner. One treatment may come out better in one area, such as dental devices being tolerated better, but usually the other option has better objective results when it comes to lowering sleep apnea severity. But if you use dental appliances more, it all seems to average out. The other factor to consider is that unless you personally have tried both options, you can't tell which option works better. And you really can't go by what the studies say, since they're done in very controlled settings with good follow-up and support. In the real world, it's not that ideal with all the different treatment options. Another example is with PAP machines. Which is better, CPAP, APAP, or bilevel? I remember reading a study many years ago that answered this question, and essentially about 1/3 preferred each group. There was no clear winner. Everyone had different preferences and different outcomes. Now when it comes to surgery, it's not something that you can just try. But even here, there are studies that try to answer questions such as which is better, CPAP or UPPP palate surgery. This was an older study by Dr. Weaver, who compared 18,000 veteran CPAP users to about 2,000 who underwent palatal surgery. When you looked at survival at the end of the 5-year period, patients who used CPAP had a 31% higher chance of being dead. The basic premise here is not that surgery is better than CPAP. What this confirmed was that a suboptimal surgery with a historically 40% success rate also had a 100% compliance rate. But CPAP works only when it's used properly. Unfortunately, CPAP compliance overall at the end of 1 year is dismal. We know that CPAP can be used effectively in up to 80 or even 90% of patients with good results, but it has to be done properly with intense follow-up and support, something that our current system can't do properly. For the 3 major treatment options, PAP therapy, mandibular advancement devices, and surgery, all seem to work well in the ideal research-centered setting. But in the real world, all 3 are less than ideal. Ultimately, your chance of success depends not on the particular device or surgical technique, but on the level of service, follow-up, and support, the passion of the practitioners in each area, and your own personal preferences. As a general rule of thumb, whenever somebody asks me what's the best treatment option for sleep apnea, if conservative options don't help, then start with either a dental device or CPAP, whichever one's that's easier and faster to try. Make sure to work with a practitioner to fully troubleshoot any problems you may encounter before moving on to the other option. Surgery should never be the first option, but one area where I have a low threshold to offer surgery is nasal surgery, especially if conservative options don't help control nasal congestion. Studies have shown that improving nasal congestion can dramatically improve success with both CPAP and dental appliances. Surgical options in the throat are a topic for another discussion since it's so vast. I hope this video dispelled the 5 common myths and misconceptions about sleep apnea. The truth is that there's no one proven solution for obstructive sleep apnea. There are many different ways to approach it, and sometimes you'll get lucky and find something that works for you on the first try, but many of you will need to move on to try other options. And some people end up combining multiple suboptimal options, such as using both a CPAP machine and a dental device together. And don't think of surgery as a cure. Think of it as a form of complementary therapy. I talked about the benefits of nasal surgery previously, and even if your major throat surgery for sleep apnea only dropped your AHI by 50% from 50 to 25, that means the damaging toll of your sleep apnea was cut in half. And more often than not, it allows the other 2 options, such as CPAP and dental appliances, to work better. My final thought is that all of these options can complement each other. Even if you find one that works for you, your situation may change in the future and you have to consider another option. This was a high-level discussion about sleep apnea treatment, taking off from common sleep apnea myths. But for many of you, you're not ready to ask which treatment option is best. Instead, you may be asking what you or your children can do to prevent sleep apnea from happening in the first place, or try to minimize its long-term effects. Remember that I mentioned in the past that crooked teeth are a sign of potential sleep apnea in UIRS in the future? Take a look at this video on how to prevent crooked teeth.